So our next speaker that I'll invite up to the stage is Jackie Brander. Jackie is NHSBT Head of Operations. Jackie qualified with a diploma in higher education in nursing and commenced her nursing career in renal medicine and transplantation. During this time, became acutely aware of the issues faced by renal patients and those awaiting an organ transplant. Jackie is passionate about organ and tissue donation and transplantation. Jackie.
Thank you. Thanks, everyone. So I'll just wait for my slides to appear. But firstly, it is a privilege to come and speak with you all today. As was just mentioned, my name is Jackie Brander. I'm the Head of Operations for Donation within the Organ and Tissue and Transplantation Directorate of NHS Blood and Transplant. I've spent 20 years working within the field of organ donation, both as a specialist nurse for organ donation and also more latterly involved in the delivery of the service that NHSBT provide. I have got experience as a dual role coordinator as well, so donor and transplant coordination, but actually started my nursing career as a renal nurse in renal medicine and then renal transplantation. So I have had the opportunity to, I guess, experience both sides of the journey. Today, I'm here to update you on all things organ donation on behalf of NHS Blood and Transplant and what we're doing as an arm's length body to meet the needs of patients like yourselves or colleagues that are awaiting a life-saving kidney transplant. So, firstly, just to say that only about 7,000 people, so about 1% of people who die each year will die in circumstances that make organ donation possible. Of these, last year, 1,510 went on to be deceased organ donors, and collectively, these organ donors enabled 3,700 transplants, deceased donor transplants to happen. As an organisation, NHSBT, as I said, is an arm's length body and we're responsible for organ donation services in the UK. Our ambition is to continue to grow and develop, and you'll hear us talking about that quite a lot, and I will discuss that with you today in terms of our progress. But our specific responsibilities as an arm's length body include supporting transplant centres with matching and allocating organs to recipients, maintaining the national transplant waiting lists for patients in a national database, which you'll know is the UK Transplant Registry, the management of the NHS Organ Donor Register, and for those of you that might have seen some of the social media around the September Organ Donation Week, it's just celebrated its 30th year anniversary, which has made a huge difference to the number of organs available for transplant. We also commission the national organ retrieval teams, which are our specialist surgeons that attend all organ donations and retrieve the organs for transplantation. They're cardiothoracic and abdominal surgeons. And we employ all of the specialist nurses for organ donation throughout the UK, including the devolved administrations, to provide a 24-hour service for the identification, referral and care of potential organ donors in the United Kingdom. In addition to that, we also have the assisted function on behalf of the Human Tissue Authority. So we have a responsibility to ensure that we maintain regulatory compliance, but also oversee the regulatory compliance of the transplant units where patients have obviously had their kidneys transplanted. So this is our most recent strategy in terms of organ donation and transplantation. So some of you will be familiar with it. It's the Organ Donation and Transplantation 2030 Meeting the Need, and it covers donation and transplantation collectively, including living, deceased, paediatric and neonatal, and all organ groups, so a very wide strategy. We have had a journey to get here, though, and some of you in the room will be well aware of our journey, but just to sort of recap, there's been a number of key papers in focus that's really helped us to increase the number of organs available for transplantation. In 2008, we saw the Department of Health Task Force recommendations that recommended that organ donation should become part of end-of-life care. The 2020 strategy then focused on consent specifically, but obviously knowing the timeline of that, you'll all recall that that was also when the COVID pandemic hit. and our most recent strategy that I just referred to, the 2030 strategy for meeting the needs. The initial success of the 2008 task force recommendations saw an increase in referrals of these potential donors. So gone were the days where there may have been a thought that there was a patient that died in an intensive care unit that wasn't referred for organ donation and the family weren't approached, and that then became the norm. So people were identified as undoubtedly the building blocks of the improvement that we've seen in deceased donation, and the ask was that all parts of the NHS must embrace organ donation as usual, not an unusual event, and also that each trust and hospital throughout the UK should have an identified clinical lead and a trust donation committee to help achieve this. And the 2008 task force asked for the first time that our specialist nurses be embedded within the critical care areas of all of our hospitals to ensure a comprehensive and robust specialised service. I was actually based at Nottingham University Hospitals when this recommendation came into place, having been myself and a colleague were one of the initial trial schemes for embedded coordination, and I have to say the change in the trust in terms of embracing organ donation at trust level and at a clinical level was fantastic to see. So the 2030 strategy is taking it a step further, and it talks about living and deceased donation becoming an expected part of care, so moving from usual to expected, where clinically appropriate and for everyone in society. And, you know, it really wants it to become a societal norm, and we are starting to see that when we talk to families. They expect donation to be discussed. On the slide behind me, you'll see the outline of the demand, the transplant waiting list, and we know that the demand for organ transplants is continuing to increase throughout the UK and, of course, outpacing the growth in transplant activity, and that obviously contributes to growing transplant waiting lists. You'll see the red line using the annual data described there on the screen, so a year-on-year data of the active transplant list, the kidney transplant list. But I know we get a weekly update, and I know from the data that I received yesterday, there are currently 6,299 patients actively listed awaiting a kidney transplant in the UK, and that's a 13% increase on the same time period last year. Here you can see the number of transplants undertaken, which, as I've said, although you can see that slight increase post-COVID, it's not quite meeting the demand that we'd hope. In terms of deceased donation, just to put some of what I'm going to talk about shortly into context, I think it's important just to describe the two types of deceased donation that we see in the UK. So DBD is donation following brainstem death by neurological criteria, and that's defined as an irreversible loss of brainstem function, loss of both the capacity for consciousness and the capacity to breathe. DCD is donation after circulatory death and defined as a patient whose death is diagnosed and confirmed using cardiorespiratory criteria. And of course, the two key differences there is the DBD patient will go to theatre having had death pronounced, but their heart will still be beating and organs perfused. And with a DCD donor, they will have passed away on the intensive care unit with their organs then removed for transplantation. They are slightly different. The DBD donor will provide a higher number of organs generally available for transplantation based on the patient's age and history, but we're now progressing into an era of novel technologies, so actually the outcomes in terms of DCD donors and the number of organs for transplant are hugely increased. So just in terms of our international position, again, you will see here that we have a slightly different mix of donors from some of our international colleagues. And that, as I say, is we have generally a 50-50 split now of DBD and DCD, and that's changed post-COVID. And that is partly just in terms of patient pool and demographic, but also the number of the patients meeting criteria for neurological death testing. So going back to this particular slide, as a patient waiting on the active kidney transplant waiting list, you might wonder why there's such a scarcity of organs available for transplant. And in order to be what we would describe as an eligible donor, as I've said, you must be intubated and ventilated on the intensive care unit and cared within that environment, and only 1% of patients will die in this circumstance. And of course, it's important to note that not only are there circumstances in which one can donate organs are so unique, we also have a significant decrease in our eligible pool. So since the COVID pandemic hit, we have seen an 8% decrease in the number of patients that would fit into that criteria. One of the assurances we can give is that we have accurate data that describes the number of potential organ donors in the UK. We have something called the Potential Donor Audit. It's probably one of the best, if not the best in the world. It's completed on a daily basis by the specialist nurses across the United Kingdom. And with that data, we can see if a patient that would have been a potential organ donor firstly was referred for organ donation, where the family approached, and of course whether or not consent took place. And that gives us a lot of confidence in terms of the data that we present. And you'll see much of it, obviously, on our website. Our regional organ donation teams across the UK, we provide a 24/7 service, 365 days a year, to support the identification, referral and facilitation of all deceased organ donors to provide organs for transplant. We have 12 teams that you can see on the map, and our specialist nurses all work within their agreed region. However, you will be aware that they cross-cover into outside their borders for periods of high activity. So again, just to give that assurance that we would never miss an opportunity in terms of organ donation, because our specialist nurses will travel outside of their own region, and in fact also work in clusters. For example, cross countries is the cluster that you sit within today, which is Midlands, South West, South Wales and South Central, so right down to the south coast. So potential organ donors that are admitted to intensive care, obviously following a sudden unexpected medical emergency, and when the team caring for them have determined that death has occurred or that death is inevitable, they will make a referral to our service. The National Institute for Clinical Excellence advises that patients should be identified and referred as potential donors, so we have that support in terms of the NICE 135 guidance, and we continue to pride ourselves really on those strong relationships that we've built with the intensive care units, and that both during and after the pandemic, they continue to maintain those high referral levels that you'll see on the slide in front of you. Year to date, this year, 24-25, we've got 95% referral of all potential deceased donors in the United Kingdom, which you probably wouldn't see any other clinical areas where you get that sort of confidence in the statistics. In terms of those very, very small numbers that aren't referred, some of them may on assessment be found later not to be suitable, but just to give assurance, we look at every single case on a regional basis, one by one, they're reviewed clinically, and plans are made with the local intensive care unit for any learning, any missed opportunities. So we're really, really pleased with our 95%. The approach for organ donation, of course, requires expertise, and it shouldn't be something that's ever mentioned to a family ad hoc, to relatives who find themselves in this unexpected and untimely situation. There's a lot to come to terms with, particularly around the circumstances and the futility of the situation. So our specialist nurses' involvement in that conversation is crucial. As healthcare professionals, everyone involved in the care of these patients wants to do their very best by the patient and their family. And of course, it's important, therefore, that the patients referred to our organisation at NHS Blood and Transplant with enough time for us to make that clinical assessment, assess the patient's history, check the NHS organ donor register in terms of any pre-known decision, and of course, support to make a planned approach to the family. We'll structure that conversation around the family situation and working with our clinical colleagues. And we'll go on to talk about the legislation shortly, but regardless of whether a patient has opted in on the NHS organ donor register or the deemed legislation applies, we want to enable that every family is supported through what we would consider to be a truly devastating time. And what we want them to be able to see is what it would feel like to be able to help someone and what that might look like. So just in terms of public opinion and consent rates, because I think consent rates will be something that you're all particularly interested in this group. So this slide talks about a public attitude to the NHS, and you'll see down the other side in the red our consent authorisation rate. And it's true to say that the two go hand in hand, really. So during COVID and during the pandemic, we, as you can see on this chart, had probably the highest consent rate we've ever achieved. We had huge support from the public as a whole. We're now in different times, and we would describe consent and authorisation, as it's known in Scotland, the law is slightly different, is probably somewhat of a wicked problem, in that it's ever changing, and we have to work with the current, the population and the pool that we serve. That's probably, there's a lot of frustration in the NHS. We can't all get to a GP, we can't get a GP appointment, we can't get outpatient appointments, and sometimes people have been on very long journeys before they come and meet with a member of our team and talking about organ donation. And one of the things that we also need to pay attention to is being able to ensure that the public actually understand what the legislation means for them. So looking at the legislation across the United Kingdom, England, Scotland, Wales, Jersey, Guernsey and Northern Ireland all have opt-out legislation in place. Isle of Man are expected to follow suit shortly, potentially in 2025. They've currently appointed an implementation officer to lead on that implementation. And if we look at the legislation in England for a moment, we know that we've got the highest number of potential deceased donors here in England itself. The legislation became effective during the COVID pandemic, and whilst the legislation applies, we know that from our specialist nurses that quite often the families aren't aware of what's expected, so the public aren't clear on what they need to do. Obviously, the government set the legislation. Our role is to really operationalise how that is put into place. I think there's probably a lot of assumptions that you've automatically opted in. So if you do nothing, you think you've opted in, when in fact that's not the case. It simply means that if the criteria is met and there's no last known decision of the donor not to donate, that we apply the deemed legislation, and we apply that obviously as part of our discussions with families. So we know that one of our challenges is to work with other stakeholders to ensure there's much more public engagement and reaching out so that the public really know what's expected of them. But ultimately, the most important thing that we can encourage, and I would ask you to encourage after today, is to encourage people to make their decision known, whether that be opt-in or indeed opt-out, but to make that decision known on the NHS organ donor register. In all circumstances where the legislation applies, an approach will be made to the family. And in England, sometimes what we also find now is that the families will say that the individual themselves had previously discussed that they did not want to be a donor. So that might have been something they'd seen on TV, for example. And in the English legislation, that actually counts as a last known decision to opt out, and we have to honour that. These are the statistics that you'll see with regards to consent and authorisation rates. So where the individual has opted in on the NHS organ donor register to donate organs or previously expressed in their lifetime that they'd like to help others following their death, the benefits are huge. So 90% of families will honour that decision and support organ donation in these circumstances. You'll see that it falls when we apply the deemed legislation. So again, that will fall to 47% in terms of consent authorisation. We see various variances between the deemed legislation across the board. So Northern Ireland and Scotland both sit around 71%. And again, they had very different implementation packages. So in Scotland, it was a mail drop at a time post-COVID when probably everybody was at home and was reading their mail. So they had a very, very high interest, I guess, in terms of their population. And also they asked people to consider their unwillingness to donate, which is very, very important in terms of clarity around what we're asking them to do. And Northern Ireland specifically have held quite a huge campaign. They've had a lot of investment in their campaigns across Northern Ireland, and the little lad that you see on the screen is Darthy, who's awaiting a heart transplant, so he's quite often within the public domain and absolutely winning hearts and minds to get yourself onto the organ donor register. For those that have not opted out or the legislation doesn't apply, so these include our children, they'll be classed as an other group. So if you're visiting the UK, for example, the deemed legislation does not apply to you, and therefore you will be in the other group, and that sits around 43%. So just to stress the importance really of the opt-in and encouraging others to do so. And currently around 28 million people have opted in on the organ donor register. So looking at consent rates over time and including ethnicity, you can see there's a real variation here in terms of consent rate from the families that we talk to. Overall, meeting the need amongst our diverse population remains a challenge. And on the screen, you can see that ethnicity plays a part in consent. Only 2.8% of eligible deceased donors are Black, and we see a 29.3% consent rate. And only 6% of eligible deceased donors are Asian, and we see a 33.2% consent rate. And it's important because obviously for some of these patients and groups, they're more likely to have problems that might require a kidney transplant in the future. To put this into context, obviously just thinking about matchability of organs from a kidney perspective, for a Black patient in the UK, they'll wait around 22 months for an organ kidney transplant, Asian patients for 20 months, but for white patients it would be 15 months. So again, there's a lot of work going on to really engage to ensure that everybody knows the benefits of organ donation and bust myths and support. Part of that work has been via the MBTA, which we've, as an organisation, been engaging with to encourage donation from these groups and provide a better understanding of donation and any myth busting within local communities. There was a conference held back in June. It wasn't a conference that I was at, but a number of my colleagues were, and that involved faith communities to promote living and deceased organ donation against the Black, amongst the Black, Asian and minority ethnic communities. So we would expect to have an official report on that imminently. So I think that's one to watch out for. In addition to that, we also have the NHSBT Community Grants Programme, which started around 5 years ago and is part of NHSBT's commitment to build support for donation amongst Black, Asian and mixed heritage groups. And we know from the work that they've done that the most effective way of engaging with communities is through trusted local organisations, and that's really important. You know, they've got the specialist knowledge and the footprint, if you like, of the community. And as has been described by Umar, who's provided this slide, it's about doing for and with our communities and not doing to our communities. And this is the type of projects that the scheme can enable. So you can apply for funding. There's a lot of information available on our website to try and increase knowledge around deceased and living donation in the community via various different methods, videos, festivals, and so on. So why then, if we haven't seen an increase in the deceased organ donors, have we seen a steady increase in transplantation from deceased donors? Well, part of that is that we've seen this change in the makeup of the donor pool, but we've also seen a change in the use of advanced technologies as well as a focus on organ utilisation. And by organ utilisation, I mean the action of making practical and effective use of all organs from any of our identified potential deceased organ donors. So each of the units across the UK for transplantation will have been asked to appoint clinical leads for utilisation, known as CLUES, and they have that trust oversight around utilisation within their hospitals. I think another key factor is the increase in organ transplants, but despite having a DCD pool, is the use of novel technologies. And by novel technologies, I mean these. So there's obviously we've got the usual storage solutions that we use, but we're really moving into a field of machine perfusion technologies. Again, a lot of this was pulled out in terms of our strategy going forward. And I think it is probably the future that will continue to make a real difference. So the UK's hospitals and research institutions have always been at the forefront of innovation. And for anybody that has looked at the strategy, it talks about assessment and recovery centres. They're called ARCs. All seems very sci-fi, but actually it's fast approaching, and there's probably not many conferences that we would go to in a clinical domain that these aren't spoken about. And that will enable much more structure to the process of organ donation in terms of being able to approach and consent and characterise a potential donor, and using some of this technology to maintain the organ either in one of the devices that I just showed you, but in one of the assessment centres in the future to find the right patient and ensure it's fully suitable for transplantation. It would inevitably increase the number of kidneys available for transplantation, so it is on its way, which is really fantastic, and this is the type of treatments that some of our surgical colleagues are exploring. Just before I finish, I just wanted to talk briefly about liver donation on behalf of my colleagues who facilitate and support liver donation in the UK at NHS Blood and Transplant. So Lisa Burnap, our Associate Director for Liver Donation, and Jen Lumsden, our Lead Nurse for Liver Donation. And just to say that it should be something that everyone is aware of, and I'm sure you are in terms of this particular audience. But again, as I said, it was part of the 2030 strategy, and it really wanted everyone in society to be aware of liver donation, and we're clinically appropriate for everybody, and making sure that it's available to you as a patient who will benefit. Transplant First is threaded through the strategy, so around that benefit really of the preemptive transplantation for some patients, so really continuing to strengthen that, and awareness of the UK living sharing scheme. There are, of course, many advantages to living kidney transplantation. So kidneys from living donors are more likely to work straight away and remain working for longer. And that's because the donor quite often won't have had the hemodynamic instability that the deceased organ donor will have. So in terms of that catecholamine storm that you might experience when you become neurologically brainstem dead. And there's also a personal, health benefit for the patient. I mean, it's a fantastic outcome, living donation transplantation, huge economic benefit, and also from a carbon footprint benefit, obviously in terms of that reduction of plastic waste in terms of dialysis if you're preemptively listed. It also takes just months to arrange a kidney transplant from a living donor, and it can last for 20 to 25 years, so fantastic outcomes. You'll see here post-COVID that we haven't quite recovered to the rate that we would hope. So really, really encouraging potential donors to come forward. And most living transplants, as you'll see, still do come from a related donor. But of course, it's important that you know that they don't need to come from a living donor, from a compatible donor, as the living donation scheme does include the non-directed altruistic donors as well. And the advances in the matching runs that we've now got from our schemes also can consider obviously the age mismatch, so grandparent to child and so on. We've also got new technology, and it might be something that you want specifically for one of your next events to have a whole session on living donation and transplantation. The Living Path technology that we've now got within the organisation enables really clear communication between centres once a patient has been identified and matched. And undoubtedly, we're the largest scheme in Europe, which is fantastic. I don't know if I've stuck to time because the timer isn't working, but just to say, in terms of everything that we've been speaking about today, I think it's really important that we acknowledge the donor families, those deceased donor families, and those living organ donors, who undoubtedly, without them, we're absolutely grateful. So thank you. Thank you.
Thank you, Jackie. A wealth of information there. So I'm glad we're going to be circulating the slides for people to digest. We're slightly running late, so I can take a couple of questions. If you can wait for the microphone, please. Over here on the left. Yep, welcome to you. Yeah, it's getting there. Okay.
Thank you. West London, KPA, Brian Turner. You're talking about donors. I'm going to ask a very pertinent question. Age-related kidney donors. Bearing in mind the cost and the cost effectiveness, is there an age cut-off?
For deceased organ donors?
Not for the deceased, for the, for anybody of my age group, for example, which is well into my 80s.
My understanding for the living programme, obviously I can come back to you with a definitive answer from our living donation colleagues, but it's based on your comorbidities overall, so your general health. I don't think there's a bespoke age upper limit, but I can confirm that to you. But I think it's much more around your health as a potential donor.
Would it be advantageous to have a donation before dialysis, if possible?
Yeah, absolutely. Yeah.
Now, the other part of the question, the second one, is the name of the BAME community contact. I missed it on.
Umar Malik, yes, and the slides will be available. I will be here for coffee as well.
Thank
so
you
yeah,
very
Umar Malik.
Thank you.
Thank you.
Thank you. We had one at the back, and then one at the front, and then we've got Kirit over there.
Hi there, my name is Mohammed Islam. Everyone calls me Izza. First question is, have you got a spare kidney? Okay, that broke the ice. I just wanted to make the point, I find it quite frustrating sometimes where there's a massive emphasis around organ donation week for 1 week in a year, and it affects us in every facet of our life. So why isn't there no more awareness around, obviously, the fact, like, you know, you do with cancer and dementia? My second point is around cultural awareness, and I see this all the time. There should be more of an emphasis where, you know, I know within our culture people say, oh, well, it's against our religion. Well, which religion tells you not to save a life? All it takes is for you to get in touch with an imam and put something on a leaflet to say it's against no religion. You know, and you've got to be 100% before you donate a kidney and expel all the fears and misconceptions. Thank you. Good presentation.
Thank you. I mean, your second question I'll take first. Thank you. Is in terms of the communities and cultural awareness, obviously that's where the grant scheme will really come in and really engage in locally. So I think as a patient group, you know, you should take that forward within your communities, and Umar's details are on the slides. In terms of the publicity, you're absolutely right. It's one of our biggest frustrations as well, in terms of, you know, trying to promote organ donation. As always, it's funding related in terms of the amount of money that we have and the publicity. And you'll notice with an organ donation week, predominantly what you see out there is led by the communities, led by the specialist nurses. There are lots of things you can do. There's a Race for Recipients is one of the big events that has a lot of traction normally in the UK, but I think absolutely hear you. It's one of our frustrations as well.
Thank you. So we've got one question in the front and then Kirit, and then we'll have to break.
Hi Jackie, my name is Rahana Korsa. I've been 11 years kidney transplanted last week, and I'm also an ambassador for the Bradford Teaching Hospitals. My question is for patients to have the uncommon blood group match, how long are they waiting for a transplant?
That isn't information I would have directly, I'm afraid, because my role is predominantly organ donation, but we can find out for you and feed that back via the group.
Thank you.
Okay, last question from Kirit.
Thank you, David. I'm Kirit Modi. I'm from the Lister Area Kidney Patients Association. It's nice to meet you. Can I say, fantastic presentation, but there was too much there in a sense. I think if I summarize that, I think there are two issues here which affect kidney patients. First, we have the largest number of kidney patients waiting for an organ ever.
Yeah.
Yes, that's a fact. Yeah? And mostly it's to do with COVID. Yes. And I do want to thank formally, I think, the specialist nurses and the staff in hospitals for the amazing work they did during COVID and what they're doing now to recover from COVID. Because I think we really appreciate that. And, you know, all of us going out there on Thursdays and banging whatever and so on. We've not forgotten that, yeah? The second thing I would say is that you talked about the change in law, yeah? And we're hoping that that will bring about miracles, didn't we? Yes, that's what the expectation was. Now, it's 4 years since the law changed in England. And there has been, as you know, I know you didn't mention it, but an independent study of the impact of the change in law in England. And that regrettably is saying that there's been literally no change at all. In fact, they're saying more than that. They're saying that the messaging we use, all of us used, during after the change in law was confusing.
Yeah.
Yes. So you mentioned the conference, the NBTA conference, which a number of us were involved in, and you're right, the report is going to be published soon and so on. So that's really saying that we need to change the messaging on opt-out, because opt-out has not had the impact which we were hoping to do. But I think picking up the other comments is NBTA and NKF, and David, we've talked about this before. I think the challenges are great, yes? Things are worse than they've ever been for kidney patients. I think that's the reality in terms of organ donation and transplantation. But that doesn't mean there isn't more we can do. And I think NKF and NBTA, we want to work with you. We already do work with Anthony Clarkson and other colleagues in NHSBT to see what we can do more together to try and address these challenges. Thank you.
Thank you.
Thank you, Kerry. Just before we break, how are people finding the temperature in here? People? Are we hot? Warm? It's just me then. Okay. Right. So enjoy your coffee. When you hear the bell ringing, please hurry back. Thank you very much.